content. share application, share camera, نشوف share file. picture. اوكي خليني اسويها كذا. واضحه سلايد عندكم الان؟ حركت؟ اوكي good. طيب so the objective of today's lecture is to recognize steatorrhea as a particular type of malabsorption and understand the severe nutritional consequence if left untreated. And we will briefly explain the reason for malabsorption in macronutrient, including the impact of different reasons. And finally, we will conclude by describe common vitamin and mineral deficiency in Saudi Arabia. We will focus on vitamin D, B12, and iron as the most common type. So briefly, gastrointestinal tract is designed to digest and absorb the nutrient. And this happens from the first part of gastrointestinal tract, the mouth, till the last part, which is the colon. However, each part is kind of specialized to do specific things. So the upper part of the body is mainly designed for mechanical and chemical digestion. And what we mean by chemical digestion is digestion by the enzyme. The bulk and the main part of the digestion and the absorption is the small intestine, while the bulk of reabsorption of the water and formation of the stool in the colon. So as you can see in this slide, all parts participate in this process. However, the main process is happening in the small intestine. That's why when we define intestinal failure or short bowel syndrome, it is when we remove the small intestine. So we will move now specifically to fat absorption. To understand the steatorrhea and the fat malabsorption, we need to understand how we absorb the fat. So first part of the digestion of the fat happen in the mouth by mechanical digestion by the tooth and by action of the mouth or lingual lipase. However, we all know that the food does not stay long for in the mouth. So this digestion has only minimal effect on the fat, in the fat digestion. Then in the stomach, there will be again an addition 5% of the digestion by the gastric lipase. But the main bulk of the digestion is in the small intestine. And in this picture, in this cartoon, we will go in a bit details of how the fat get absorbed. So fat is usually a hydrophilic molecules. So it does not move easily in the water or in the aqueous solution. And it comes in a very large molecule as it is shown in the slide on the left side. So this large molecule cannot move in the aqueous solution, cannot be absorbed. So the bile will come to this large molecule. Keep in your mind that the bile has two pools or two surfaces. One surface is hydrophobic and the other surface is hydrophilic. So this bile acid will come to the lipid, to large molecule of the lipid, and will detergent the large lipid, the large molecule of the lipid. This will make lipid is in a smaller, as is shown. I'm not sure if my arrow is showing to you, but this large lipid will be break down into a smaller lipid molecules. Okay, let me try to see. Yes, now the arrow is clear. Okay, so this large lipid, by the action of the lipid, will convert it into a smaller lipid molecules. What is the importance of doing this? This will allow the important enzyme in the digestion of the lipid to work. So the lipase, the pancreatic lipase, the pancreas now will secrete the lipase, which is the most and the principal enzyme in the digestion of the lipid, and will break the triglyceride. When lipase from pancreas will break down the triglyceride, this triglyceride will be converted to free fatty acid and a monoglyceride. This free fatty acid and monoglyceride, after emulsification, this process where we convert the large lipid molecule to smaller lipid by the action of the bile acid, called emulsification. So the first step in the digestion of the lipid, which calls emulsification. After the emulsification and after the action of lipase, where the large triglyceride lipid converted to a free fatty acid and monoglycerol, then again the bile acid will surround this free fatty acid, cholesterol, and fat soluble vitamin. So all fat content, cholesterol, free fatty acid, monoglyceride, fat soluble vitamin, will cluster in the center and will be surrounded by the bile acid. And this molecule is called micelle formation. So micelle formation is the second step in the lipid digestion, and it is very important to enable this hydrophilic molecule to attach to epithelium. And then after this micelle formation attached to the epithelium, it will release the fat content, free fatty acid, cholesterol, fat soluble vitamin by diffusion, and this bile acid will be released in the terminal ileum, or in the lumen of the bowel, and in the terminal ileum, this bile acid will get reabsorbed and recirculate to do the cycle again, while the fat will enter the enterocyte. The free fatty acid, the monoglycerol, and the cholesterol, and the fat soluble vitamin. In the epithelial cell, it will attach to Golgi apparatus, and then a very important point or step where molecules called apoprotein, because remember, now there is no bile acid. So again, the lipid cannot move in the aqueous solution, so it cannot move inside the body. So it needs to attach to something to make it more water soluble. So in Golgi apparatus, it will attach to a protein called apoprotein. Attachment of triglyceride to a protein, apoprotein, result in formation of chylomicrons. Is the milky structure we see it in the lymph. So chylomicron is what form the chylus, where we call it chylus. This chylomicron will enter the lymph and it will get absorbed. And in this picture, you're gonna see the structure of the chylomicron. Okay, so this is the structure of the chylomicron. So in the middle, we have the phospholipid, we have the triglyceride, we have the fat soluble vitamin, and this will be attached, but what we call it apoprotein, which will make it more water soluble. Then after we understand how fat absorption happen by first emulsification of the fat by the bile acid, then formation of the micelle with the help of the bile acid, and then inside the enterocyte, the lipid will attach to apoprotein and make chylomicron, and then the chylomicron will be absorbed by lymphatic system. Keep in your mind that fat soluble vitamin does not need a digestion by lipase enzyme from the pancreas. However, it needs the micelle formation and it will need the chylomicron formation. What we call it medium chain triglyceride, which is a smaller than triglyceride, a smaller size than triglyceride, does not need chylomicron, because chylomicron will carry the heavy triglyceride which cannot move in the blood freely, while medium chain triglyceride, what we call it MCT, is a lighter, so it can be absorbed directly into the blood. So what is the steatorrhea? So steatorrhea is increased the fat excretion in the stool, and this will lead the appearance of the large, bulky gaseous content of the stool, and this stool tend to float because there is, as we said, the lipid will not easily mixed with the water, so the stool will be hard to flush, foul smelling, and it will form like an oily layer. So what is the causes of steatorrhea? If we understand how the absorption of the lipid happen, we can figure the causes of steatorrhea. So first, we said the pancreas will secrete lipase enzyme, which is an important step in digestion. So if there is a pancreatic insufficiency, then there will be steatorrhea. Pancreatic insufficiency happen in cystic fibrosis, in Schwann-Diamond syndrome, and in pancreatitis. Again, we said bile acid and bile salt is very important in emulsification and micelle formation. So if we have a problem in bile acid, there will be steatorrhea, such as in cholestatic liver disease or in bile acid synthetic defect. Brush border is important because we said the micelle will attach to enterocyte and then will get by passive diffusion inside the enterocyte. So if we have a brush border problem, there will be no transformation of the lipid from the lumen to the enterocyte, and this has happened when we have ileal resection, celiac disease, short bowel syndrome, when we have a problem in chylomicron formation. Because again, we cannot absorb, the lipid cannot move from the enterocyte to the circulation, and this has happened in a congenital disease called abetalipoproteinemia or hypobetalipoproteinemia. And the final step when we have a problem in lymphatic, because as we said earlier, it is not the blood vessels, it is the lymphatic vessels is the channel where the lipid is carried. So if we have a problem in lymphatic system like intestinal lymphangiectasia or Whipple disease, then we will have a problem in absorption of the fat, which can result in steatorrhea. So what is the complication of steatorrhea? So fat is very, very, very important nutrition molecule. It is a high energy density, and it is very important, especially in pediatric, for neurodevelopment, because we need an essential fatty acid which comes from triglyceride for a normal brain development. So malabsorption, then this will result in a weight loss in the adult and the growth failure in the kids with the poor neurological development. If we have, and this will result in deficiency of vitamin A, D, E, K, which is a fat-soluble vitamin. ADIC is our fat-soluble vitamin. Because of the deficiency of vitamin D, there will be a poor bone health, which result in osteopenia, osteoporosis, rickets. And another complication common in steatorrhea, because fat is not absorbed, the fat will tend to, in the lumen of the gut, will attach to calcium, and this will make the calcium oxalate molecule deprived from the calcium, because the calcium will attach to the fat, will leave the oxalate free. This free oxalate will be reabsorbed by the kidney, where again it will be attached to the calcium molecule, and it will form oxalate stone in the kidney. So patients with fat malabsorption they have a high tendency to develop oxalate renal stone. How we manage steatorrhea? By managing underlying cause. So if you have cholestasis, if you have pancreatitis, if you have, it depends on your underlying cause. The most common cause is pancreatic insufficiency. So if you have pancreatic insufficiency, you need to supply your patient with pancreatic enzyme replacement therapy. If the patient having short small intestinal bacterial overgrowth, you treat it. If the patient have celiac, you treat it. So the main cornerstone of management is treating underlying cause. Keep in your mind that you will need to supply the patient with fat soluble vitamin to prevent fat soluble vitamin deficiencies. We finish from the lipid, we're going to move to carbohydrate. When we speak about the carbohydrate, we speak about different type of carbohydrate. So the body usually absorbs the monosaccharide. The monosaccharide is a single one molecule, and this is the part which the body is capable to absorb. However, carbohydrate can exist in disaccharide, which is sucrose, and sucrose will form from two monosaccharide, which is glucose and fructose. Lactose is formed from two monosaccharide, which is glucose and galactose, and maltose formed from two glucose molecular. While oligosaccharide, the size of oligosaccharide is from 2 to 10 sugar molecule. Polysaccharide is more than 10 molecule, up to 100 or 200. And the best example of this is the plant fiber, starch, glycogen, cellulase. And as you can see, the monosaccharide, because it is the simple, easy, ready to absorb molecule, while the polysaccharide is the more complex sugar, which need first to be digested and then absorbed, while the monosaccharide can be absorbed directly. And we're going to see this in the next slide. So as we said, monosaccharide, glucose, galactose, fructose absorbed directly through this receptors, which is SGLT1 and GLOT5. GLOT5 for fructose, SGLT1 for glucose and galactose. So glucose molecule, fructose molecule, galactose molecule will directly absorb through this carrier. Keep in your mind that this is an active, not a passive process. This carrier will carry the monosaccharide with an expense of ATP energy, where and this is sodium coupled carrier. So 2 sodium will enter in with the glucose. So what happens if we ingest disaccharide or polysaccharide? So if we ingest disaccharide like lactose or sucrose, this is the enterocyte and this is the brush border of the enzyme. So in the brush border, there is a digestive enzyme for carbohydrate. For lactose, we call it lactase. For sucrose, saccharase. For maltose, we call it isomaltase. So this brush border enzyme will cleave for example, lactase will cleave the lactose into the glucose and galactose, and fructose will be break down to fructose and galactose and isomaltose to glucose, and this will convert the disaccharide to a simple monosaccharide, which is then be ready to be absorbed. If we eat a polysaccharide, if we eat starch, if we eat fiber, then the digestion process is more complex, and this is where we need the help of pancreatic enzyme amylase. And this process actually started from the mouth by the salivary amylase. But again, the same as we said in the fat, the food stay only for a few minutes in the mouth, so only 5% of the digestion happen in the mouth. But then by the action of pancreatic enzyme, which will be secreted in the duodenum, this starch will be converted to maltose, pectin, and other smaller sugar. And again, by the effect of brush border enzyme, this will be breaking down further to glucose, galactose, and the fructose will be absorbed in the enterocyte. In the enterocyte, again, the glucose will leave the enterocyte to the bloodstream by, again, an active transportation by enzyme called GLUT2. So again, entering of carbohydrate into the enterocyte and leaving the enterocyte, both is an active process carried through a special carrier. So what is the causes of carbohydrate malabsorption? The same as we did in the lipid. If we understand, then we'll. So we said that if we have a starch or complex sugar or complex carbs, we need a pancreatic enzyme amylase to digest. So pancreatic problem in the pancreatic enzyme, like cystic fibrosis, Schwann diamond, will cause malabsorption. Keep in your mind that this will cause malabsorption only in complex sugar, because we don't need amylase for if we eat a simple sugar like a glucose or lactose. If we have, and this is the main cause of diseases in carbohydrate malabsorption, because as we said, the final step, all poly and oligosaccharide at the end will need to be digested by the brush border enzyme, lactase, isomaltase, saccharase. So if we have a brush border problem where this enzyme will be inactive and cannot work, then we will have carbohydrate malabsorption. So the most common example is lactase deficiency, saccharase deficiency, isomaltase deficiency, or if we have a problem within the carrier, like a GLUT, or so if we have like congenital glucose galactose malabsorption, or if we have both, like if we have short bowel syndrome, celiac disease, or if we have a problem in the transport. So no, okay. Yeah. Okay, we finish now from carbohydrate, moving to a protein digestion and absorption. The main role player in the protein digestion is the pancreatic enzyme. So protein is a large molecule which formed from di and triple and oligopeptide, and this oligopeptide is formed from the basic of the protein, which we'll call it amino acid. So in protein we have the basic block, which is the amino acid. If the amino acid join together by special bonds, will form a peptide. If this peptide join, will form a protein. So the large molecule of a protein, once minor digestion will happen in the stomach by the action of the enzyme pepsin, which is secreted from parietal cells. So, but again, it is only very minimum. The larger part of the digestion happen, or the main part of digestion happen in the duodenum, where the pancreas will secrete the pancreatic juice. This pancreatic juice include the trypsin, chymotrypsin, and other enzyme. This enzyme will be secreted from pancreas as an inactive form, because imagine that if this will digest the protein and it will be secreted as an active form, this will digest the pancreas itself. So it needs to be secreted as inactive form, and this enzyme will be activated in alkaline media in the duodenum, mainly by trypsinogen will be activated by enterokinase, and once trypsinogen is activated, will this convert the trypsinogen to trypsin, and the trypsin will activate all other pancreatic enzymes. So by the action of this trypsin, chymotrypsin, and all other enzymes, the protein will be converted to oligopeptide, which is a smaller molecule. And then oligopeptide will be, if it is amino acid, then this amino acid will be absorbed directly into the enterocyte. If oligopeptide is in form of di or tripeptide, then again, this di and tripeptide need to be digested to a smaller or to the basic block, which is the amino acid. The same idea with the carbohydrate. As we said, the carbohydrate can be only absorbed if it is monosaccharide. Protein is absorbed as amino acid. So we need to convert all protein to amino acid, either by action of pancreatic enzyme, and once it formed a smaller di or tripeptide, in the brush border, there is an enzyme called enteropeptidase. This enteropeptidase enzyme will convert the di and tripeptide to amino acid, where it will absorb in the enterocyte, and then it will go to the circulation. So again, what is the causes of protein malabsorption? If we understand how the absorption happen, we get to understand the malabsorption. So pancreatic enzyme is a very, very common cause of protein malabsorption. Cystic fibrosis, Schwann-Diamond syndrome, if we have a brush border disorder. If we have enterokinase deficiency, as we said, enterokinase is important. If we have di and tripeptide, it will break it down to amino acid, which can be absorbed. If we have absorption in the carrier itself, on the protein, and this is happen in the congenital disease like Hartnup, lisinouric protein intolerance, Lewis syndrome. So all these are a congenital metabolic defect. Or if we have a problem in the transporter like intestinal lymphangiectasia. So to summarize the cause of malabsorption, we have either luminal cause. What we mean luminal cause is within the lumen of the gut, and this is mainly deal with digestion. Or if we have a mucosal problem, or and then this is may have a problem with the digestion or absorption. Or if we have a transport phase, and this is will deal with the absorption. So luminal phase digestion, mucosal phase digestion and absorption. Transporter is with absorption. Luminal phase, the most common exam is pancreatic insufficiency. As we said, pancreatic enzyme have a main role in lipid and the protein, and some role in carbohydrate malabsorption, defect in bile acid, and we went through all these causes just to summarize everything and make it clear in your mind. So we finish now from micronutrient, carbohydrate, protein, and fat. We will move to the second part, which is vitamin and mineral. Again, as we said earlier, main absorption happen in the small intestine. In large colon, we have only vitamin K, which is produced by bacteria and absorbed there, and some electrolyte after, because the main function of the colon is to reabsorb water and make the stool more formed. So sodium, chloride, potassium will be absorbed in the large colon. But the mineral, vitamins, all absorbed in the small intestine, different part. So most, as you see here, most of the vitamin and mineral will absorbed in duodenum, and to the lesser extent in the jejunum and ileum. So we will move to the first and most common vitamin deficiency in Saudi Arabia, which is vitamin D. How do we absorb vitamin D? So we usually we have in our skin 7-dehydroxy cholesterol in the skin, and by the action of the sunlight, and it is the special wavelength between 290 and 350, which we call it ultraviolet B, because we have A, B, C. So this is in the middle. This will be converted to vitamin D2, and then this will go to the liver, and it will be hydroxylized there by the adding of one molecule of OH, and this will convert it to 25 hydroxy vitamin D. and this is the inactive form of vitamin D. This will go to the kidney, and another OH molecule will be added, and it will convert it to an active vitamin D, which is 125. This vitamin D acts as a hormone because it will go to the kidney and it will promote the absorption of more calcium and from the kidney and from the intestine, and this will help in increase calcium in the serum, which will be used in bone mineralization. So what is the normal serum vitamin D? When it is 75 millimole per liter. This is the optimum. The sufficient is between 50 to 75, insufficient 30 to 50, and deficiencies when it is less than 30 mole. What is the function of vitamin D? As we said earlier, the most important function is increase bone mineralization or bone formation. It has some others rule, like increases cell differentiation, increases insulin secretion, increases calcium absorption. So what is the symptoms of vitamin D deficiency? If we have mild deficiency, you may complain of mild headache, sleepiness, some diarrhea, some sadness, malaise, and mild joint pain. However, if you have a severe deficiency, then you have a muscle weakness, fracture, multiple fracture, and painful bone and joint. Vitamin D deficiency has been reported in the literature to associated with some diseases. In adult, it has been associated with schizophrenia, TB, asthma, osteoporosis, osteomalacia, renal failure. And in pediatric, there has been few reports about the association of vitamin D and asthma, reduced bone mass, and rickets formation. From where we get vitamin D, as we said, from sun exposure is the main source of vitamin D, and from the diet. And this is the main source of vitamin D in the diet: dairy products as the cheese, yogurt, milk, egg, and fish. How we treat vitamin D, it depends on the level. So if we have a very low level deficiency, then we give 50,000 international units weekly for 6 to 8 weeks, and then we put the patient in the maintenance. If we have a higher level or insufficient level, 30 to 50, then we give from 800 to 1,000. In pediatric, the recommended dose for maintenance is 400 to 800. However, if we have a deficiencies, we're going to give 1,000 to 2,000 international unit, and then we check the level, and based on the level, we adjust the dose. Moving from vitamin D to B12 to iron. So iron deficiency is again one of the most important deficiencies in Saudi Arabia. So we in the colon, the ferric will be reduced to ferrous, and this will absorb by special receptors phytotransport into the enterocyte, and then once it enters the bloodstream, this iron will be attached to transferrin, which is the transporter molecule for iron. We get the iron from the diet, or we get it from the breakdown of the RBCs, the old RBCs in the reticuloendothelial system or macrophages. So we have two sources of iron, dietary iron and within the blood itself. Then this iron will be transported to the bone marrow for erythropoiesis and hemoglobin formation. The dietary, as well as the release of iron from the macrophages of reticuloendothelial system, is under tight control by the protein called hepcidin. Hepcidin is released from the liver. So if we have a high iron in the blood, then the liver will sense this high iron and it will secrete hepcidin. Hepcidin will downregulate the iron transporter receptors in the enterocyte. So it will shut down the transport of the iron from the blood to the from the lumen, sorry, to the blood, as well as from macrophages or reticular endothelium to the blood. So hepcidin is a very important regulatory factor in the iron transportation. So from where we get iron, we have two types of iron, heme and non-heme. Heme iron is where it comes from the animal source. Non-heme source come from planet source. The heme or the animal source has more absorption and more bioavailability than the non-heme. However, because we eat more planet, I mean, it depends really on the diet, but generally we eat more planet than the animal diet. So the major source is the planet, while the main bioavailability and the main absorption is from heme iron. What causes iron deficiency? As we said, diet is the source of the iron. So diet is again a source of deficiency. So if we have a decrease in the intake of especially the restricted vegan diet, because as we said earlier, the vegan will provide us with non-heme, and non-heme has a poor bioavailability and absorption. Vitamin C has been reported to increase the absorption of vitamin of the iron. So if we have vitamin C deficiency, it may affect the iron. Blood loss from GI, from menorrhagia, from cancer, from hematuria or coagulopathy, any cause of blood loss, or a problem in absorption. So as we said, it will iron will absorb through special receptors in the enterocyte. So if we have a problem in the brush border where this receptor is lost, then you will have malabsorption, as in celiac disease and enteritis and H. pylori. Inflammation, like inflammatory bowel disease. If there is increase in need, and this is what we call it physiological anemia, like in pregnancy, early in childhood, around 9 months to 1 year, in athletes, other disorder like iron metabolism disorder. Anemia symptoms is wide, and it can affect any organ from headache, fatigue, low blood pressure, palpitation, chest pain, enlarged spleen, paleness in the eye, shortness of the breath. If you have GI losses, then the blood in the stool will change the stool to plaque-terry stool. How we diagnose iron deficiency anemia? So if we have hemoglobin less than 12 in female or less than 30 in male, then we do transferase saturation. If it is less than 20%, if the ferritin is low and MCV is low, then this is iron deficiency anemia. If ferritin between 300 to 100, which is not very low, then we go for the transferation log, which is a special like curve. And if it is high, then this is iron deficiency anemia of a chronic disease plus iron deficiency anemia. If we have low hemoglobin, low transferrin saturation, but the ferritin is high, then this is anemia of a chronic disease. So iron deficiency anemia, low ferritin, low MCV, low transferrin, and low hemoglobin, high RDW. How we treat it? We treat usually with oral therapy. So we give oral iron supplement. However, if the patient did not improve or the patient did not tolerate the oral therapy, then we can give IV iron. And actually, in special circumstances like in inflammatory bowel disease, and the patient has a low hemoglobin of 10 or 11, we prefer to go directly to IV iron without even a trial of oral. Moving from iron to B12 absorption. So B12 has a special way of absorption. So in the stomach, the B12 will be attached to what we call it intrinsic factor. This intrinsic factor is secreted from parietal cell, as you see here, and it will be attached to the B12. and then this will move all the way down to the terminal ileum here. In the terminal ileum, the B12 intrinsic factor will be attached to the enterocyte, and then the B12 will be released into the enterocyte and then in the circulation. So B12 absorption happen in two steps, in the stomach and then in the terminal ileum. So what is the risk factor of B12 deficiency? As we said, the absorption in the ileum. So if there is an ileal disease, then there will be a B12 deficiencies, like a Crohn's disease, ileal resection. And if there is a problem or decrease in intrinsic factor, if there is atrophic gastritis, so there is no parietal cells to secrete intrinsic factor, if we have what we call pernicious anemia, or if we remove the stomach totally. Genetic disorder like transcopalamin deficiency will result in B12 deficiency, or if we have inadequate intake, like patients on alcohol abuse, or very elderly patients, or restrict vegan diet. Because again, it is similar to the iron. B12 is more the bioavailability and absorption of B12 is mainly from animal sources. A prolonged medication use, especially if we use acid suppression, metformin use, which is the medication used in diabetic, have been associated with the B12 deficiencies. So how we diagnose B12 deficiency? B12 level less than 200 has high sensitivity. However, if we wanted to increase this sensitivity, then we add what we call methylcobalamin, because methylcobalamin will be binded to B12. So when we don't have a B12, there will be increase in free methylmalonic acid. So if you have a B12 deficiency, then the methylmalonic acid will be high. What is pernicious anemia? Pernicious anemia is a chronic autoimmune gastritis where the immune system target the parietal cells of the stomach. So there will be no intrinsic factor, and this will result in B12 deficiencies. How we treat B12 deficiency? Again, we treat the underlying cause the same as the others. We give intramuscular injection of cobalamin, cyanocobalamin, or oral vitamin B12 therapy. So the guidelines of British Society recommend injection 3 times per week for 2 weeks in the patient without a neurological deficiency. Over the patient, if the patient have a neurological deficiency, then the injection need to be given every other day. How long it will take after the treatment for the symptom to resolve? If you have only anemia, it will take 1 week. If you have a neurological symptoms, it will take 6 weeks. The longer duration for the symptoms resolution will happen in anemia, leukopenia, or thrombocytopenia, which may take up to 8 weeks because it needs to replenish the bone marrow. And thank you. Do you have any questions? يعطيكم العافية جميعا.